So mainly what we're going to do here is, this is my effective side because I'm going towards my effective side. Okay? I'm going to interlock my hands in a prayer position so that my effective thumb is on top. Because the nuances are that now my thumb is abducted, which is an RIP. Okay? If you do it the other way, it's wrong. Effective thumb is on top. Okay? Now what I'm going to do is I'm going to push my hands towards the ceiling to protract my shoulder, which is an RIP. I'm going to bring my legs up into flexion, because I got hip and knee flexion, which is an RIP. And now I'm going to segmentally begin with my shoulders, and I'm going to roll to that side. Okay, that's how we do the rolling bit. Bridging. Get patient supine, knees and hips flat, arms out bilateral. Ask patient to lift arms to the ceiling. Support the patient by ankles if necessary, and try to have them lift the bottom off the surface. So, as opposed to what we did this morning, same position, knee and hip flexion, which is an RIP. In the prayer position, pointing my arms towards the ceiling, getting nice protraction. And now what I'm going to do on my own, I'm going to bridge. And then that's going to be a precursor to trying to scoop the head of the bed or laterally. Okay, a little bit different than what you did this morning. So we need to work on bridging. If my effective leg keeps flopping out, what do you need to do? Help me out.
Cross it under.
You need to help support it. Okay? You need to support it. Scooting. In that position, we're going to scoot towards the head of the bed, or we're going to scoot laterally. Just like this morning, under traditional mobility, under NDT mobility, bridging is a precursor to scooting, but you are employing these specific skills. Usually a common error on the lab practical is, for whatever reason, people forget to do the RIP of the arms. And they just bring their knees up and decide that they're going to bridge without the RIP of the arms, or they're going to go to their side without the RIP of the arms, and it's wrong. Total body RIP. Break up the tone to allow for a more normal pattern of movement. Nice and slow. You cannot impose normal movement on abnormal muscle tone. Always encourage transfers. It's really working. Always encourage towards the hemiplegic side, maximum, moderate, and minimal. We're going to do that right now. Feet flat on the floor. Scapula is protracted with the hands flat. This is essentially to break up spasticity before transferring. Now, I'm going to demonstrate these rather than just talk through them. When we get to a moderate, okay, we're going to help out here again. Alright, so here is true theoretical NDT. Okay, Jake is simulating weakness on the right side of his body. I am going to do a max transfer. So, main thing here is not so much working on his mobility as much as it is working on getting him from point A to point B. Hey, can all of you stand up for a minute? Okay? And we really have to be careful. You're good. You really have to be careful with these chairs, but I just want you to put two chairs side by side. And I want one of you sitting in one of those chairs and the other one standing up. If the other one's standing up, hold both chairs still. Now, all I want you to do is get to that chair that's unoccupied right now. Okay, so there was a different form, but the point is, what you did not do, none of you did, none of you stood all the way up and then made a step and sat down. At least a few of you made that kind of just that transition, right? That's one of the things that Bobath really looks at in terms of normal movement. And what we're going to do is the same type of concept. Empty. With Jake, all right? Now, this is traditionally done without a gate bell. We know gate bell is policy in many institutions. We can adapt this with the gate bell. But I want to show you without the gate bell first. What we're going to do is, the first thing is Jake's going to interlock his hands. So this effective thumb is on top, it's abducted. Now what we're going to have Jake do is we're going to have him go into trunk flexion, and that's going to break up extensor tone in his back. We're going to have him drop his arms over his opposite knee. And we're getting protraction of the shoulder. We're getting an RIP into that right arm. Extension of the elbow. It isn't perfect, but that's what it is. We have an RIP in the back, RIP in the arm. And by nature of the position of his hip and knees and ankles, is that an RIP in this affected leg? The answer is yes. So, Bobath, it looks like this. What I'm going to do is I'm going to pull Jake forward, kind of like what you did with a sliding board transfer. His shoulder is literally in your hip. Okay? Now, this is true Bobath. What you need to do is you're coming over and you're literally grabbing on the greater trochanter, which means you're grabbing on the glutes. Okay? And what we're going to do here is on the count of 3, we're going to transfer. 1, 2, and 3. And believe me, you can take a big person, and as long as you do this right, you can make it work. The whole thing is not lifting. It's pulling Jake literally towards you and making that transfer. Go ahead. Change again, okay? So it's going to look like this. Reflex inhibiting pattern. Get the arms there. RIP here, RIP in the back, RIP in the leg. Open stance, just like you had this morning. I'm on the effective side, going in that direction. I have that leg between his legs. I'm coming over here. Sometimes you even got to get a little more to the side. You got a good grab on the glute. That's your point. That's a key point of control. That's what it is for Bobath. I can lift literally Jake up. Jake, sit down. Sit down. I mean, really, you know, it takes some strength, but I have pretty good, so it's 1, 2, I got my key points of control. The glutes, shoulders here, he's not going anywhere. All we need to do is make that pull and pivot. Pull and pivot. I kind of use my hip too. Yeah. Kind of use my hip. Okay, so you should find this not to be all that incredibly difficult. It's all about technique. Let's do the moderate transfer. Moderate is different. Interlock those hands, drop them over your knee. Same position. Now what I'm going to do is, and we'll do it so that you can see the back here. I'm on the lateral scapula. My key points of control. Here, I'm doing 2 things. Point A to point B, but I'm also trying to get this guy helping himself out. So what we're going to do here is we're going to go 1, 2, 3, and I'm going to pull Jake up a little bit, and we're just going to make that transition, kind of like what I was hoping would happen when we did our little experiment there. Moderate, 50-50, right? 1, 2, 3. We're going to have a seat. Here's minimal, same thing. Obviously, he's doing most of it. 1, 2, 3. Okay? So that's Bobath. Go ahead and turn around. So Max looks like this. There, get that RIP. Here, I'm right here. 1, 2, and 3. Max transfer. Moderate. Notice my key points of control. There, not up in the actual. Between here, not quite the same conservation of H. 1, 2, up, and pivot. Minimal. 1, 2, 3. Let's pull back, okay?